Thanks for joining us, everybody. I'm Tristan Barrett. I'm a radiologist in Cambridge in the UK. We're going to discuss our point-counterpoint argument with the HAR, which is whether we should update PI-RADS 2.1. So I'm presenting the point that it's time for change, and I'll hand over to my colleague who's presenting the counterpoint.
Hi, I'm Leo Kayat, Vice Chair of Innovation in the Department of Radiology at University Hospitals in Cleveland and Associate Professor of Radiology at Case Western Reserve University. And I'll be discussing the counterpoint for updating PI-RADS right now.
So I think probably what is helpful is for us to go through a couple of slides of the background to this. The first version of PI-RADS came out in 2012, actually termed the ESUR prostate MRI guidelines, retrospectively called PI-RADS version 1 when version 2 came out in 2015. The first version focused particularly on the acquisition parameters and talked about minimal and optimal protocols. Version 2 in 2015 concentrated more on the scoring system, was more explicit in how we come up with a probability score of clinically significant cancer, and introduced the concept of dominant sequences. Importantly, also dropped spectroscopy and reduced the role of DCE. The current version is version 2.1 from 2019, only version 2.1 rather than 3 because the changes were relatively minor, aimed particularly at the scoring system. 3 years from version 1 to version 2, 4 years to version 2 to version 2.1, and now we're at the 5-year time point. So inherently you think maybe it is time for change. It's important to state that PI-RADS is not just about interpretation, which is what we perhaps think about. It's also about the acquisition. Synthetic calculated DWI is now widely available on the majority of scanners. We're also starting to see the introduction of post-processing with deep learning reconstruction from AI algorithms. You can see an example there from our practice where at the same quality, we can halve the acquisition time. But you can use it in other ways to improve quality. And if we think about interpretation, well, there's been quite a lot of publications, again, mainly consensus documents rather than evidence-based, and particularly looking at the post-treatment gland. So precise in the context of active surveillance follow-up, PI-RR in the context of previous treatment with either radiotherapy or prostatectomy, and PI-FAB in the context of focal therapy. But also, quite crucially, I think there at the bottom, which is related to all MRI of the prostate, in the treatment naive or post-treatment gland, is quality. Image quality is key, and PI-POR version 1 and version 2 have come out since 2019. Another couple of things to note, biparametric MRI is absolutely something people are talking about. The PRIME study presented their results in the EAU conference earlier in 2024 and showed essentially no difference between biparametric and multiparametric MRI for outcomes. But important to note here is that these were experienced radiologists in bigger practices and with a central review of quality to ensure that the MR quality was high enough to take part in the trial. Since 2019, in 2022, the ACR RADS program have come out with a white paper. They've set a higher bar at which to change guidelines. One is relevant to the counterpoint of staying with the status quo, is actually you need quite strong evidence in order to put forward a change in guidelines. But I'd also highlight that if it's not going to have a major effect on patient care, the bar is still as it was before, that it can be based on consensus expert opinions. Another bit of background is this systematic review that was published earlier in 2024. And to highlight, if we look at the different PI-RADS scores, we can see on the bottom there that clinically significant cancer at a grade group 2 or higher threshold obviously goes up as the PI-RADS scores go up. If you look at on the right, PI-RADS score 3, intermediate, presence of clinically significant cancer is equivocal. PI-RADS 4, high, clinically significant cancer is likely to be present. Well, I think if you look at the purple bars there, 49 for a score 4 is essentially 50-50. That doesn't meet the definition of is likely to be present. That seems more equivocal to me, whereas 16% seems it's quite a low probability. So I think semantically those definitions are slightly questionable, but that's the current position that we're in. That was a large systematic review, 70 studies in the PI-RADS version 2.1 era from March 2019 to August 2022 and involving 13,500 patients. So it's a quite good quality data. So that's a bit of a background to where we are. What I want to do is to hand back to Leo and for you to detail the literature search that you did in and around this paper, which was, I think, a very interesting aspect.
So when we were working on this Counterpoint, we thought that it would be important to understand, first of all, that nobody's against, right, the need and the interest for a change and for an update. So we were only working on the reasons as to why haven't we gotten an update so far, and you elaborated on some of them. But we also wanted to have a feel on what are the proposed updates that people would like to see. And based on the literature alone, we conducted, and that credit goes to my co-author, Dr. Leonardo Kayat, that we looked at all the publications that had terms that indicated any type of adjustment, change, modification, improvement, update, and the term PI-RADS in the title and in the abstracts. And that amounted, since 2014, that amounted to 607 publications overall. But then most of those, the vast majority, the overwhelming majority of those, they were not dealing with PI-RADS alone, with the document PI-RADS. The overwhelming majority, they were trying to incorporate either labs, biomarkers, genetic testing, sequencing of decision-making, or extraneous nomograms or proprietary decision-making processes. So they didn't quite apply to our discussion at hand as updating PI-RADS, the core of PI-RADS. And then after we narrowed that down to 22 publications, and even among those 22 publications that were dealing with PI-RADS itself, there were many of those that were proposing to incorporate PSA density, which is something that we are doing already intuitively in our day-to-day. So there were 22 publications that dealt with what we consider as generally a PI-RADS only attempt at a modification. But when we looked at the full text of those 22 publications, so imagine in 10 years, there were only 22 publications that were trying to modify PI-RADS itself. Only 5 of those, they contained the type of evidence and the type of measurements that, and the presentation of results that would meet the needs and the requirements of the current RADS Oversight Committee document. And to explain what is it, is that not only they say that potential modifications that affect clinical care, they need to be addressed by adequately powered prospective or retrospective studies from one or multiple institutions, but also that they need to incorporate measurements that reflect benefits and harms of incorporating such a measurement. And again, to viewers, to exemplify what does it mean, is that it doesn't suffice anymore to say that if I introduce the technique that my department developed and I found that it increases the accuracy to X, Y, and Z over the current PI-RADS standards, that means that, of course, that PI-RADS has to incorporate it and it's a done deal. And it's not like that anymore, because you also need to evaluate if you are driving more unnecessary biopsies by doing that technique, or if you're driving up the overall costs of detecting clinically significant cancer as opposed to missing out clinically significant cancer. So this cost-benefit, harm-benefit analysis needs to be incorporated in any or most studies that are willing and aiming to propose a change to any RADS systems. So based on that literature search, we tried to be very open and comprehensive. We found only 5 studies that would fully comply with those very conservative guidelines. So that's the overview of the literature search. And I'll hand it back to you, Tristan.
Yeah, I mean, a really interesting exercise that you looked at there. And I think it highlights a couple of things. One is that 600 plus publications in that time is a lot, right? So it's a really fertile area of research, but obviously only very few are meeting that stringent bar that the ACR are talking about that you've applied. And I think the other point to make is that guidelines don't change every year. I mean, there has to be some sort of structure to this and some sort of rules in play, because you can't be changing the way you practice on a yearly, 2-yearly basis. You do need time for a system to bed in, for people to assess it and to look at the outcomes. And that's not specific to PI-RADS, that's across all types of guidelines. We have the NICE guidelines that we use, particularly in the UK, which is cross-cutting across all of medicine and surgery. Specific to urology in Europe, the EAU guidelines, and they also apply similarly high bars of evidence, and they tend to be reactive because they need that evidence to accrue and to be of high quality for it to impact on practice. So I don't think it's anything unusual that there has been a period of time, but it's also, I guess, is the time to think about the evidence that you've gone through, some of the changes in practice that I've detailed, and whether it's time to change them. I think one thing to particularly note is that, as I've said, it's interpretation and it's acquisition. Mm-hmm. And when we come to the acquisition side of things, which isn't always as evidence-based or needing to be, there are, depending on how you count them, around 35 different parameters that are stipulated in PI-RADS. And only 7 of those changed in 2015. So actually 28 of them are unchanged since 2012, which is 12, 13 years, which is a long time in MRI and with developments. And I highlighted a couple of the developments there. But what we also know is that if you rigidly stick to those parameters, you don't always get good quality imaging. And there is room, I think, to look at those. For instance, the ACR actually, it's slightly contradicting itself because it badges PI-RADS as well, recommends an in-plane resolution for T2 of 0.6 millimeters squared, whereas the phase and frequency recommendations in PI-RADS are 0.7 times 0.4, which is quite difficult to meet, and obviously that risks introducing noise. So I think that there's areas where we know we can improve things with synthetic imaging, as I said, with potentially with deep learning reconstruction. So that's an aspect of the PI-RADS document that could certainly be looked at. And it comes back to image quality as well.
I agree with you. And that does not go against the RADS Oversight Committee, as you said, because acquisition parameters, as long as they do not affect the clinical decision-making and they only improve image quality, they are the type of discussion that can be dealt with. And there are technical ways to do it to avoid going back to the problem of being based on only expert opinions, right? And the point that I forgot to make when I was discussing the literature search is that the whole goal of this position paper from the RADS Oversight Committee is to avoid the risk of having strong and powerful voices in a room that drive a panel to adopt a certain resolution that will resonate to the whole world, right? And that has happened in the past to many different, not only RADS, but different panels that you and I or everyone else has participated. And the goal is to also to be able to incorporate more democratically, more diverse voices and the evidence that there is. As you know, I've been practicing here since 2020 in the US, but I practiced in Brazil for more than a decade before. And over there, in many other countries that are not in the immediate center of the decision-making of those types of programs and criteria, we take the published documents as the very gospel, right? So whenever I think of PI-RADS, whenever I think of those guidelines, I don't think of a high-end, top-notch researcher in a big academic institution that is already involved in those discussions upon inception. I always think about myself many years ago when I was looking for guidance on how to act, or people in Africa trying to make the best in addressing their population. So I think that's what probably helps justify why PI-RADS is being conservative in driving out those recommendations, because of the power and the universality of the PI-RADS recommendations themselves. And as you said, NICE has in the UK has a way to address its local needs, problems, requirements, network, business models, and budget, right? The same way the AU, the same way the AUA here. But when you talk about PI-RADS, it's also an exercise of connecting and weaving together all the best way possible, all those recommendations, and also all the other neighboring societies, right? So I think that speaks to the challenge.
And I think I highlighted PI-Qual, and I think quality is something that we've been really cognizant of in the community, and it's an MRI is not an MRI. So in one center versus another, and you will have your own limitations in your own practice. If you have an MR that's 7-8 years old with older software, you have to work within those confines, and we can't be in an ivory tower and say everything has to be at 3T with a magnet that's 2 to 3 years old and with the latest software and deep learning reconstruction. It's not practical. But optimizing that quality as much as possible is key. I think that there is scope with PI-Qual to perhaps be more harmonized within an updated version of PI-RADS. As it stands, PI-RADS mentions quality superficially, and it talks about things that can affect quality. It doesn't explicitly make recommendations on patient preparation. It also make some comments here and there. For instance, if you lose one, or if you only do biparametric or both functional sequences, if you do multiparametric, then it states explicitly that the exam is limited to staging only and is not for lesion detection. But it doesn't really bring in those elements of quality control that PI-Qual talks about in quality assessment. So I think certainly that's an area where the next version of PI-RADS, whenever that comes out, could look at. I think we've mentioned the elephant in the room of biparametric MRI a couple of times, and regardless, that is coming. There's several advantages to biparametric, but it has to be done in a sensible way, in a controlled way, with experienced radiologists, with good quality imaging, where what quality has been confirmed, whether that's through a process like the ACR program of assessing centers, or another process in other jurisdictions. And I think that's another room for PI-RADS to potentially come in, or to come in with an update. There was a narrative review, which I think was helpful. And perhaps that's the way, perhaps that's the halfway house, is narrative reviews rather than frequent updates of the guidelines. But the narrative review, whilst helpful, it tended to list times at which multiparametric MRI was preferred, as opposed to times at which biparametric without contrast could or even should be used. And I think a dedicated biparametric MRI, or more explicitly biparametric MRI scoring system, should be a consideration, because we know in the current PI-RADS, what will happen is that the PI-RADS score 3s will go up if you apply the current system. And there needs to be a way to deal with that, or to mitigate against that. And whether that's something like augmentation with PSA density, or stipulating that if biopsy is not to be performed, then there are other checks in place, for instance, a repeat MRI after an interval. But I think a more dedicated biparametric MRI scoring system should be considered. And we might come onto it later, we'll see, but screening is on the horizon as well. And we know for sure, if we want to be as least invasive as possible. So that would not include contrast. And also we want to maximize specificity rather than sensitivity in a screening program with a naturally lower incidence prevalence of the disease. So that would be biparametric. And that's, again, another paradigm. But But biparametric, one way or another, is certainly more on the horizon.
I fully agree with you with this order of prioritization, and I could say that those are all integrated as I heard, but I believe I heard three main things. So one is to incorporate and harmonize the need for addressing quality. And because PIPO has been so successful, maybe PIPO might be the way to go and to incorporate that to PI-RADS. And I fully agree with this view. Also, more clarity on biparametric imaging. And the reason you brought it up altogether is because ultimately the caveat of biparametric is how to perform it while ensuring the quality, right? Because as I like to say, biparametric is not an excuse to do a sloppy exam. You need to up your quality more than your multi-parametric to compensate the information that you're not getting. And I agree that being more explicit on the indications, the situations where it can be applied, the caveats that you are leaving behind, and also if there's need to adapt further the scoring system. And then the other point, incorporating PSA or not and decision-making, biopsy decisions, they have to do with the diagnostic pathways. And those are the three main topics that are probably more ready for prime time in terms of an update. But my question is, when you ask the general audience, what do they think about PI-RADS? And the general audience, I would say people who are not in an academic setting. Most of the things that we hear when they disagree with PI-RADS, they have to do with the scoring criteria themselves, with the features, with the descriptors. Sometimes people say, well, I don't apply it exactly because I prefer to use like a certain way to sort it out, right? Do you think that if PI-RADS addresses the first higher priority, more evidence-based topics that we said, will people be satisfied with an update if we don't touch the imaging features themselves, the scoring criteria, the core of the scoring system? Or what would be a path to review and examine that?
So, I mean, it's an interesting concept, and I guess relating to that, what I could throw back to you is the status quo, or the last update didn't work. In the two of the more headline reasons for doing that was to improve inter-reader agreement, and was to improve the yield of clinically significant cancer in the transition zone. And one of the ways for the latter was to introduce the score of 2+1. But actually, if you look at that, the systematic review that I presented, the outcomes of clinically significant cancer in scores 2+1 in the transition zone is around 13%. So that hasn't, to a degree, been successful. And the inter-reader agreement, when you compare earlier versions versus 2.1, there's a slight improvement, but not a dramatic improvement. So we're still only at moderate agreement. And I think what you're getting towards there is the fact that it's still quite experience-based. So the outcomes and the inter-reader agreement are better for more experienced readers. So there seems to be something in there, intangible, the gut feeling, or something that's hard to say what it is, that comes with experience. Now, what that might be, I suspect, is an acknowledgement that we have all the sequences, we have all the information, we're going to use all the information, and then we're going to make it fit. So it might be a case of working backwards, for instance. So if we say you've got the perfect quality examination, the T2, the DWI, the DC, perfect quality. Now, if we're looking at the transition zone, PI-RADS says you're not allowed to look at the DCE. You can't look at the DCE. And if we're looking at the peripheral zone, and it's a score 1, 2, 4, or 5, you can't look at the DCE and you can't look at the T2. And the same in the transition zone for the DWI. But of course, we know those other sequences can be helpful. And we tend to use those as more experienced readers and to a degree work backwards. It's either the safety net approach or it's looking at these different features. And I think that 2+1 score was an acknowledgement that actually the diffusion weighted imaging in the transition zone can be very useful, but you've got to use it in the right way. You can't just use it to overcall everything, because you will always get foci of restricted diffusion there in stromal BPH, in cellular dense nodules BPH. You have to use it correctly, and I think that's where the experience comes in. But there is evidence to suggest that if you look at the DWI first in the transition zone, and then augment that with the T2 afterwards, you do get better outcomes rather than the rigid PI-RADS paradigm. So there, I think there's scope there to loosen that slightly, or it's difficult because you want frameworks, but it's the ability to work outside that framework if it gives you better outcomes. So I think those are the other considerations, quantitative parameters, and it's something we've talked about a lot in the community. But ultimately, and at least theoretically, DWI with ADC, DCE with semi-quantitative, quantitative measures can afford you those quantitative parameters. But of course, they haven't gained traction because the variability is so high. When we're talking cross vendors, cross magnet strengths, cross generations of magnets and models, it becomes very difficult to set exact thresholds. So that would be an obvious solution, but it's a very, very challenging solution.
Yeah, those are great arguments. And one idea that always comes to mind is, well, if the RADS Oversight Committee has this position, right, and if they set the bar for what type of evidence is needed, do you think that something like a white paper from the RADS programs and the RADS committees listing the topics that they are willing to examine, and the study methods, or not the study designs themselves, but the type of evidence, the measurements that they are looking for to weigh in on incorporating those decisions, would be something interesting to the community? Or you think it would be received more as a prescriptive type of a document?
Yeah, I mean, I think that does help to focus people to develop research ideas and to work along those lines. It's something that NICE in the UK does when they do a review of existing or an update to their guidelines. They acknowledge areas where there's not enough evidence to make a decision, and they highlight those as areas of need and where to focus research. So it would be equivalent to that concept where you say, you read the evidence, you say, well, there's not enough evidence in this particular area, and that's where future research should be focused to see if we can provide that evidence to inform a future update.
Yeah, I agree.
I think we were having a very brief discussion before we start this. The nature of articles like this is that you have to take a very entrenched viewpoint and you have to vigorously defend it. But the reality is, I'm not completely on the side of change, and you're not completely on the side of being against change. We are somewhere in the middle, and I think we've detailed a lot of the arguments 2 and 4, and perhaps those having more of those narrative type reviews or position statement articles is a way between our 2 points of view that we've been asked to take, that allows to give updates or to make some recommendations without formalizing it. Do you think that's a fair comment?
I agree. Although the narrative reviews, they take longer time to produce, and sometimes I get the sense that the reader ends up reading the narrative review and they get the feeling that, wow, there's so many possibilities here to navigate and so much flexibility that sometimes I wish I had something more narrow and that would work in 80% of the time. So I think that balancing what is a recommendation document and then what is the gathering of the evidence around it, right? That bases out the recommendation. I think the narrative review would be much more this type of an exercise. What is the evidence there is around it? What is the range of possibilities around those decisions? And at the end of the day, the recommendation, at least as an end user, I would expect it to be somewhat narrower because that helps us navigate decisions. But for sure, we can be much more nimbler with papers and narrative reviews than with comprehensive authoritative documents such as what PI-RADS version 2 was.
And I think another point that you made, do you think, so for instance, the Bosniak system is not called Bosniak version 1.0, 2.1. It's just the Bosniak system for renal cysts. And people refer to 2005, 2009. Do you think that's an easier way to talk about these rather than version 2.2, 3.0?
I think this is a great idea, yes, and I'm hearing this type of a conversation. And the good thing about it is that the update being tied to a year will not imply to the reader or to the end user that the whole corpus was updated, and more so that there are new implementations that were incorporated, right? So as an example, if you drive a Tesla, right, and you get an update from the Tesla, you get a list of the new incorporations and the new features that you're getting with that update, but that does not necessarily invalidate everything that you have been doing so far. So I think that using a year number instead of a number of a version makes it easier and more palatable, right, for people to digest those updates. So I agree with you.
Okay, I mean we've had a great conversation there. I think we've probably covered all the points that we both made in our articles and more. So please check out those articles on the AJR website. And it's been great having this conversation, Leo.
Same. I really enjoyed the conversation. We could spend hours here talking about it, right?
I think so. So we better call it a close there. We'll call it a score draw. Can we say that? And we'll leave the readers to decide.
All right.
Okay.
It was great talking to you, Tristan, and I really appreciate the invitation by the AJR to contribute with you. You were a great partner in doing this exercise together.
Likewise, and thanks to Andy Rosenkrantz for inviting us to do this. Thanks,
For sure.
everybody. Bye now.
Have a great day.